Department of Clinical and Experimental Epilepsy. And today I'll be talking to you about cognitive network plasticity after anterior temporal lobe resection. Let me just try and do this myself. Yeah, so these are my disclosures and nothing related to this talk. Second. Okay, so the main objectives of this session really is to understand the dynamic plasticity effects of temporal lobe surgery on language networks, and I'll be really focusing on lexical-semantic tasks, the episodic memory, and if we have time, I'll talk about the working memory network. A little bit of a spoiler here, the star of the show is going to be the posterior hippocampus. So really watch closely, watch the hippocampus. Sarah, could you advance the screen for me, please? So we all know the anterior temporal lobe resection is associated with a higher risk of verbal memory decline as well as naming deficits, and this can be up to 50% of people in some series. After non-dominant resection, the code is about 20 or 30% of visual naming decline, but we've seen this across both dominant and non-dominant, causing verbal and visual memory declines. Now, there's also accruing evidence that frontal lobe functions, such as working memory, can be affected in people with temporal lobe epilepsy. And you see there is also this plasticity effects in working memory networks after epilepsy surgery that I will discuss with you. Next, please. So this lexical-semantic task is widely used, and this is a verbal fluency and verb generation paradigms that has largely replaced WADA testing in most centers. And in the fluency task, people are instructed to think of about as many words as possible when a letter flashes on the screen. Next screen. In a typical network, you will see here on the left in the healthy control population, you see activations in the left frontal regions. The SMA is active across most language and most tasks really, and some left cortical activations in the temporal lobe. There's a higher chance of atypical representation in people with temporal lobe epilepsy. And this is one example of a person with left hippocampal sclerosis, one of my patients, who is right represented for language. Next screen. And this is the first kind of post-operative plasticity reports from Silvia Bonelli in 2012. In the top row, you will see a functional connectivity task where she looked at connectivity patterns on a lexical-semantic task from a left inferior frontal lobe mask. And from there, you see that in people with left temporal lobe epilepsy, there's increased connectivity within the left temporal lobe before surgery. 4 months after surgery, which is the second row, you see connectivity to the right frontal lobe. And in people with right temporal lobe epilepsy, the connectivity is to the left frontal lobe, and you don't see any connectivity to the contralateral side. This is all 4 months after surgery. Next. And for the first time, what Silva shows here is really how the left posterior hippocampus is emerging a champion. The left posterior hippocampal activation, so people who did activate the left posterior hippocampus, they showed a lower risk of naming decline after left anterior temporal lobe surgery. Next. Going on from this, then Nenning et al. Decided to show the differential connectivity along the length of the hippocampus. And what they showed is a differing gradient of connectivity across an anterior-posterior axis in people with left temporal lobe epilepsy. There was disruption from the left anterior hippocampus to the left frontal lobe, whereas the pattern was quite different in people with right temporal lobe epilepsy. You see this kind of disconnection between the right anterior hippocampus and regions within the default mode network. And this might suggest some evidence as to why you see disruption in language networks in people with temporal lobe epilepsy before and after surgery. Next. This group then took it one step further to show that this connectivity pattern, this kind of reorganization of connectivity is really dependent on the type of lesion that people with temporal lobe epilepsy have. So in red is the connectivity that is greater in controls compared to the patient group. So there's greater disruption of connectivity in people with hippocampal sclerosis and more so with left hippocampal sclerosis. And if you then compare this to non-lesional left and right TLE, you can see the degree of disconnection is much greater in people with hippocampal sclerosis. Okay, next. So this is now some work done by my PhD student, Maria Sublik, who's here in the audience as well. So what we do know about the language network is 4 months after surgery, people with left temporal lobe epilepsy recruit the right frontal lobe. And if they use the posterior hippocampus, there's a lower risk of naming decline. And actually, we're quite surprised at the dearth in the literature as to the longer term connectivity and plasticity in language networks. But looking at the stroke literature, what was postulated is there is a return back to activation within the left frontal lobe in people who had strokes in the dominant hemisphere. So that was our hypothesis, that there's likely to be an increase in connectivity or activations in the left frontal lobe years after epilepsy surgery. In the right temporal lobe epilepsy patients, however, it wasn't really clear what we were going to find. So next slide, please. So in this group of people, we looked at people performing a verbal fluency paradigm 4 months, 12 months, 1 year, and up to 10 years after epilepsy surgery, and controls were imaged at all these 4 time points as well. We were then able to look at what people with epilepsy showed in terms of plasticity changes from 12 months to 10 years over and above changes in controls and a flexible factorial analysis. And you see in my red rectangle here, all the increases from 12 months to 10 years were within the left frontal lobe in both left and right TLE people. And the extratemporal regions that were activated were the putamen, so the deep gray structures and the insula. The right middle temporal gyrus in people with left TLE and the fusiform gyrus in people with right TLE. So kind of this emerging story that, come from somewhere between 1 year and 10 years, there's increased engagement or recruitment of the left frontal lobe again in people with left temporal lobe epilepsy. Next. But how did people actually do after epilepsy surgery? So if you look at these plots here, these are picture naming, phonemic fluency, and categorical fluency in people with left and right temporal lobe epilepsy and controls. Controls are in green, left TLE in ochre, right TLE in red. And the only thing to really kind of report is that is encouraging is cognitive stability. Across the naming and fluency tests, about 50% of people with left TLE improved. And in categorical fluency, both left and right TLE improved from 1 year to 10 years. Now, there's a huge caveat to this. 86% of the people in the study were seizure-free. There were 2 people who had worsening of seizures, and those 2 people, both their memory functions and their language functions declined. So I suspect, the picture that we see with neuroplasticity is quite different with people who continue to have seizures. Next, please. Then what Maria did is she then correlated these activations with improvements in the naming functions as well as fluency functions in people with epilepsy. And you see that in people with left TLE, that left posterior hippocampus is still associated with improvements in naming 10 years after surgery. And you see these deep gray structures such as the caudate and putamen being important in this network for recovery of language functions. In people with right temporal lobe epilepsy, improvements in these functions was related to activations in the left frontal lobe. Next, please. So what happens to structural connectivity over time? This is a very interesting study by Moreira de Silva et al. And you will see they report decreases in both left and right TLE versus controls at 4 months after surgery in the tracts that are resected during surgery. So that's expected, the I4 and the uncinate fasciculus in left and right TLE. But what people with left TLE showed is increases. In particular, this really caught my attention, was the corticostriatal path as well as the corticospinal tracts. And these increases were primarily ipsilateral, so ipsilateral to the side of resection, so the left in left TLEs. Mahinda Yogaraja in 2010 showed a very similar finding in that there was reduction in FA in the tracts surrounding the resection, but more anteriorly, particularly in people with left TLE, in the external capsule and the posterior limb of the internal capsule, there was increased FA, and this correlated with post-operative verbal fluency scores. So we like this emerging picture that there's early structural connectivity at about 4 months after epilepsy surgery. But again, we don't know what happens 9, 10, 11 years after epilepsy surgery. And this is really watch the space for language functions, and this is ongoing. Next, please. So just to summarize what we know about language so far, they're both functional and structural networks associated by reorganization processes in TLE. 4 months after surgery, you see engagement of the right frontal lobe in left temporal lobe epilepsy. And longer term after surgery, you see a shift back to this left frontal lobe. But both the left and the right are important in maintaining improvements in language functions long term after surgery. And the structures really that are critical to these include the deep gray structures in the posterior hippocampus. Time will tell whether this connectivity to the corticostriatal structures is reinforced in the longer term. Next. Moving on then to long-term memory processes. And for today's talk, I will focus just on episodic memory. And next, please. So as you all know, episodic memory is made up in encoding and retrieval. For memory encoding, you need a close interaction from the prefrontal cortex, the orbitofrontal cortex, and the mesial temporal lobe. So there's accruing evidence that that distinct neural trace is not just stored in the hippocampus, but also within the orbitofrontal cortex. Next, please. So in our center, this is the memory encoding paradigm that we perform. We've tried many different iterations and also used other stimuli, but have really focused on this because patients are able to perform this task, even people with quite difficult or really affected memory functions. And then this yields meaningful activations and robust hippocampal activations on a single subject level, which is really what we need for prediction, etc. So people are asked to memorize faces and words for future testing. And out of the scanner, we show them the same faces, the same words, and add in a few foils. Whoops. If we just go back one, please. Thank you. And people decide whether the face or word is remembered, familiar, or new. In controls, you see that for word encoding, there's primarily a left frontal and left hippocampal activation. In people with left temporal lobe epilepsy, there's engagement of the right frontal lobe and the right hippocampus. So this kind of right frontal lobe story is very similar to verbal fluency. And in people with right temporal lobe epilepsy, this verbal encoding network is very similar to healthy controls. Next. In people, and then for visual, you will see that it's more of a bilateral task, but you do see some right lateralized within the right frontal lobe and the right mesial temporal lobe. And the main thing that we see in people with left and right temporal lobe epilepsy is reduction ipsilegionally in the frontal and mesial temporal lobes on this task. But then what do we know about, next slide please, about the areas that are critical in patients, but not in controls, or over and above controls. And this is when we looked at subsequent memory. That means activations in the brain associated only with the faces and words that were then later remembered. And we see that in people, in both left and right TLE, the posterior hippocampus, amygdala, and insula are critical hubs for visual memory, and the amygdala and the insula is not really seen in controls. And the posterior hippocampus and the anterior cingulum for verbal memory. And these regions are really not critically involved in controls. So now I'm following in my head the posterior hippocampus and the orbital frontal cortex, wondering, okay, now what happens after surgery? Next slide, please. In this study, then, the focus was on the left posterior hippocampus and the right hippocampus. And you see bars here. I don't know if you can see my mouse moving, but anyway. So yes, yeah, exactly where the mouse is moving. So these structures, you see the top columns, the top bars at the left posterior hippocampus. There's an increased activation pre-surgically. Post-op 1 is 4 months after surgery, and you see the left hippocampus is slightly more. And 1 year after surgery, that activation reduces. It's not deactivated, but it reduces. Whereas the contralateral hippocampus really spins in. It comes in, it's activated, and there's an increase in activation at 12 months. And if you then look at the correlations 12 months after surgery, that insula and the right hippocampus is critical for improvements or maintaining good verbal memory 12 months after surgery. Next, please. And other studies done by Chung et al. And Jung et al. Looked and reported very similar findings in that 12 months after surgery, the contralateral hippocampus is critical for maintaining mnemonic function. Next, please. Okay, yeah. And next. Then I had this interest to go, right, okay, there's more to this story about the left hippocampus. It's absolutely critical, and as clinicians also critical from a surgical point of view. So I decided to look at the connectivity, effective connectivity between the bit of the temporal lobe that's left behind, which is the remnant mesial temporal lobe, the contralateral mesial temporal lobe, to the rest of the brain using GPPI. Next. And this is work done by Marine Fleury, who's also here in the audience. And what Marine looked at is in the same people who were imaged, as in the language data set, at 4 different time points, pre-op, 4 months, 12 months, and 10 years after surgery, with controls across performing the memory task across the same time points. And seeding from the left posterior hippocampus, so you'll see the purple blob here. Sorry, if you can bring the cursor. So the cursor on the left, correct, yeah, thanks. So you will see in the left resection group, seeding from the left mesial temporal remnant, there is increased connectivity to the contralateral posterior structures. So contralateral parahippocampal gyrus, the contralateral fusiform gyrus, and also connectivity to the right anterior cingulum. So that cingulum that popped up preoperatively in subsequent memory 4 months and 12 months after surgery continues to be important in a connectivity. And now we have this story that actually this is connected functionally to the left, the remnant mesial temporal lobe. And if you look at the right resection group below, the right mesial temporal remnant connects to posterior structures again, but that remains more ipsilateral to the fusiform gyrus and the parahippocampal gyrus, and is associated with improvements in verbal memory function. Moving on to this middle picture here, in blue, light blue, is the connectivity from the right hippocampus to the rest of the brain in people with left resections. And in dark blue is the connectivity from the posterior hippocampus. And you will see that the connectivity from the light blue is primarily to neocortical regions, the frontal lobe and the orbitofrontal cortex, whereas that mesial temporal remnant connectivity is more posterior. So to the fusiform gyrus, the occipital lobe, and the posterior temporal neocortical regions. And this connectivity to the left fusiform gyrus and the right orbitofrontal cortex is what sustains and what is associated with improvements in visual memory in people with left temporal lobe epilepsy. Next. Yeah, and next. Yeah, this is just really a little bit of a summary of what we just said. Now looking at whether there is a structural connectivity underlying these new connectivity patterns that are emerging up to a decade after surgery, we did a seeded tractogram on Nodimetrics from the mesial temporal lobe seed, from the mesial temporal lobe remnant in all patients. And to be able to compare like for like, we also then seeded from the medial temporal remnant of the control, so essentially the back. We matched the patients to the controls and took the posterior bit of the controls to be able to match the seeded tractograms. Next. And what we do see, this is in preparation, this is work that Marine is writing up. All people with epilepsy, so both left and right temporal lobe epilepsy, you'll see this new structural connectivity from the remnant to the contralesional, to the other side, basically the contralesional posterior mesial temporal lobe, which incorporates the posterior hippocampus, the parahippocampal gyrus, the fusiform gyrus, and also to the cingulum. And these new connections, particularly the ipsilateral cingulum and contralateral hippocampus, is associated with improvements in both verbal and visual memory functions in left and right temporal lobe epilepsy. And then in another way of looking at this, next please. We created probabilistic tractography of the uncinate, fornix, the molt, medial occipital longitudinal tract, because we see all this posterior connectivity and the cingulate bundles, and perform individual regressions between the microstructure and postoperative change in memory functions. And this is an example of tracks in people with one person with left temporal lobe epilepsy. And what we see here, in the next slide, please, is that the recovery, the improvements in verbal and visual memory are very much related to this new connectivity to the cingulum and within the molt. Okay, next slide, please. If we have time, we can speak a little bit about working memory in a bit, but just to summarize what we see in episodic memory, the anterior cingulum and insula are areas of efficient preoperative reorganization. The anterior insula is sustained 12 months and longer, related to verbal memory improvements in people with left temporal lobe epilepsy. You see new structural and functional connectivity from the remnant mesial temporal lobe to posterior structures, again, that underpins the improvement in memory functions in these people. Okay, next slide, please. In terms of working memory, so working memory is a frontal lobe task. This is an example of a visual working memory task. I'm sure you're all familiar with this, but this is an increasing load. So 0 dot back, you see a dot, you just press where you see a dot. 1 dot back, when you see a dot, you're supposed to press a position within this box of where the dot was 1 dot before from your memory, and 2 dot backs, you have to remember where the dot was 2 screens before this. And actually 2 dot backs pretty hard. I struggled with this one. And next slide, please. A typical network in a healthy control on the top row is a biparietal bifrontal network. And the difference is that the hippocampi are deactivated in this task. So in working memory, the hippocampi are critical. In episodic memory and in working memory, there's deactivation. And in people with temporal lobe epilepsy, they fail to deactivate the diseased temporal lobe, and that is related to worse working memory performance. Then what Jason Stretton showed is 4 months after epilepsy surgery. If you look, it says here left TLE mode and controls, and you see a blue dot in the posterior hippocampus. So 4 months after epilepsy surgery, there's increased left posterior hippocampal deactivation, and this supports improvements in working memory. And in people with right temporal lobe epilepsy, there's reduction in that active network on the right. So the right parietal activation is reduced. Next slide, please. So working memory performance is improved after epilepsy surgery, particularly in people with left temporal resections. This left temporal and this improvement really correlates with greater deactivation in the posterior hippocampus. So you'll remember preoperatively, they do not deactivate the hippocampus, and after surgery, they deactivate the remnant. Again, the remnant is coming out to be the shining star. And this really has significant impacts on quality of life. Okay, next slide, please. And just to wrap up, these findings have significant clinical implications. So what's encouraging is that we see cognitive stability and even cognitive gains in the longer term after epilepsy surgery, with the caveat that this is seen in people who are largely seizure-free. And this is really supported by ongoing dynamic, structural, and functional plasticity, and really suggests a role for neurorehabilitation, not just preoperatively or early post-op, but really any time after surgery. Professor Baxendale has set up a memory and cognitive rehab group for anyone to be referred in at any point after or before surgery, and we'll see whether that's helpful or not. So the posterior hippocampus is a critical hub, and this has implications for resection planning. How far back do you go? How much do you spare? And I'm sure you all have read this paper by Soni et al., where he described resection based on a percentage of the anterior-posterior diameter, anterior-posterior extent of the hippocampus. And there was a sweet spot at 55%. Resections more than 55% along this length was associated with greater mnemonic decline, mnemonic function decline, and smaller resections, there was a higher risk of seizure recurrence. So really trying to get this right, we need more improvements in individual mapping, which we can hopefully discuss in another forum. So thank you so much for your attention. And next slide. And I want to thank all my fantastic colleagues and collaborators at the Chalfont Center for Epilepsy, Professor Kaur, Professor Duncan, who I work with very closely, our two surgeons, Andy McAvoy and Anna Misarocci, who are vital really to this work. Thanks so much for your attention, and sorry about the slides. Okay, any questions for me? Or thank you.
I think very much. I think a question.
Yeah. Thank you for this great talk. I can hear my voice for some reason. But are you suggesting we should try to spare the posterior hippocampus in our resection on the dominant side? I think you muted.
Sorry, Meneka, I muted you to avoid the echo, so you need to unmute yourself.
You muted me. Oh, that's all right. I won't take it personally. Sammy, both the mesial temporal lobes, the remnants of both the left and right, are equally as important to one another. You would see that the connectivity patterns from the remnant right mesial temporal lobe had important plasticity engagements, both in structural and functional networks.
And if you don't mind me asking another question, sometimes it's pretty rare, but sometimes I see that on dominant side temporal lobectomies, patients have some receptive language deficit. So I know it's not described. Most of the time we talk about naming the issues and fluency and so on. Is this something you could explain?
I mute it again. Yeah, I think that this again has implications on both the active and the default mode network, Sami. So what we have seen so far is in right temporal lobe epilepsy, if you look at just the activation, you might not find any difference to controls. But if you look at the deactivation patterns, there's a disconnection from the right hippocampus to the default mode network, which might be one of the mechanisms by which we see language disruption in non-dominant TLE.
Thank you.
Okay. If there's no